As we have said, today's presentation is on a topical issue that concerns all of us here, which is meningitis. The topic is meningitis, an update and preventive measures, which is going to be delivered not by the head of internal medicine, Dr. Kabir Muhammad Mandi. Dr. Kabir Muhammad Mandi, as I have said, he is the current internal medicine head of department. He holds his MBBS from Usman Dan Fodio University in 2009, and he is a fellow of West African College of Physicians, who specializes in infectious diseases. And he left Udus, he was with Teaching Hospital Usman Dan Fodio University in 2021 before he joined us. Dr. Kabir is going to do justice to this presentation, and I would like to invite Dr. Mandi to come on the podium for his presentation. Dr. Mandi, over to you. Thank you.
Good afternoon, everyone. All protocol duly observed. I feel highly honored to stand before my teachers, mentors, and senior colleagues and sisters to do these presentations. In fact, in particular, I'm highly honored to be the first person to launch this prestigious auditorium. The topic of discussion, I think, is well chosen, looking at the fact that we are currently in the country witnessing an outbreak covering most of the northern states and even some southern states. Therefore, the topic is carefully chosen. The essence is to update ourselves or to refresh our memory, and also call attentions to the fact that although we are battling with the communicable or non-communicable disease, the communicable diseases are still with us and they are still taking lives. As the PRO already highlighted, we are going to discuss cerebrospinal meningitis. We will use the following headings, outlines. You have to be very close to it. One number. So I will try to be within time, since we have already started behind schedules. It's almost 2:30. We'll follow the following outline to do the discussions. By way of introduction, cerebrospinal meningitis, it is basically an inflammation of the brain, of the coverings of the brain. As we know, for those of us that are in the clinics, we know the brain has coverings, which we call meninges. When these coverings become inflamed, following infections, chemicals, or even blood from within the brain, that's what represents meningitis. So basically inflammation of the brain meninges. There are many things that can cause it, ranging from infectious to non-infectious causes. This disease, particularly the bacterial meningitis, is a very important and very serious illness, and if care is not taken, is not diagnosed and treated promptly, it can lead to death or even permanent damage. Another very important thing that can lead to is what we call the epidemics. As what we are saying now, we are witnessing outbreak in the country, as I highlighted earlier. We'll have some updates about the situation in both the states and within the country at large. Estimate shows that about 1.2 million cases of meningitis occurs globally, And largely we have epidemics occurring in some part of the world, and is driven by this organism, Neisseria meningitis, and which has many serogroups. Serogroups, they are like daughters of the same parent group of organism. Mainly in the past, we dealt with the serogroup A, B, and C, but we are seeing the surge of W, X, and Y. Meningococcal meningitis as an outbreak or epidemics occurs in a part of the Africa known as the sub-Saharan African region, and this particularly affects what we call the meningitis belt. This is a region in Africa that is stretched from Senegal in the south to Ethiopia in the east. About 26 countries in Africa belong to this. If you look at the map, the entire northern states in Nigeria belong to this particular region of the world, and that's why frequently we have epidemics. You remember the worst epidemic we have in this country in 2017, but even in 2023 we have another epidemic outbreak, but it's not as serious as the one we had in 2017. So this disease has, since it has a potential of epidemics, is part of what we call internationally recognized notifiable disease. So this, whenever we have cases of this disease, it needs to be notified. The Nigerian Center for Disease Control need to be notified through the epidemiology unit of the states, so that alert can be set and preparedness and prepare for eventualities, since it has the potential for outbreaks. Cases occur throughout there, but particularly within the dry season, when the weather when the hot weather becomes so intense, like as what we are witnessing now. The more the temperature rises, the higher the chance of this disease becoming an outbreak, getting out of proportions. So most peak within between March, April, up to June, before the rain set in properly to coil the epidemics. It starts from around December, few cases, but it peaks between March to April, May, as we are currently within the season. As we know, the weather is intense, temperature can be up to 40 degrees in this part of the country. All age groups are affected. Now, meningitis, particularly bacterial meningitis of the from Neisseria meningitis, affect all age groups. But some people are particularly at risk, as we will see, especially the extreme of ages, like under 5 and elderly. Transmission is through direct person-to-person contact. So when you are taking care of people with these infections, the closer you are to the person, the more at risk you are of contracting the infections. And this is particularly important to us as the healthcare workers, since we came very close to these patients. So through the droplets, sneezing, coughing, because these organisms, some of them colonize our nasopharyngeal area and the upper airway and even the mouth. So some of them, immediately you cough or you sneeze, you cough them out, and if the individual is very close to you, the chance of contracting the infections increases. So what is the situation currently in the country? This is the latest data released by the Nigerian Center for Disease Control as of Sunday. So we have, between 2024 40th week of 2024 to 12th week of 2025, we have about 1,858 cases, with about 126 cases confirmed. The fatality rate currently is about 8.4%. These states are the worst affected: Adamawa, Kebbi, Kano, Jigawa, Sokoto, Akwa Ibom, and Katsina. Ebonyi State is also reported quite a number of cases. This is unusual. Those states are not commonly they do not belong part of the meningitic zone completely, but you are seeing an extension of this infection to those part of the country. This is the situation report from the epidemiology unit of the states. About 6 local governments, including Gusau, Karanamoda, Zumi, Mafara, Maradun, and Shinkafi local governments, with about 22 so far confirmed cases and 4 mortalities. So if we look at the 4.8% case fatality rate, the disease is still we are still at the initial stage. More states are reporting cases, and more updates are getting released by the Nigerian Center for Disease Control. So what are the etiological agents for meningitis? Viruses, parasites, fungi, and even chemicals. Neisseria meningitidis particularly cause epidemics, but other infections, other organisms, Haemophilus influenza, and Streptococcus pneumonia. Streptococcus pneumonia particularly causes what we call sporadic meningitis. It's not implicated in the epidemics of meningitis. Other bacterial causes including Staphylococcus aureus, Listeria monocytogenes, especially in the elderly and the very young, the infants. Then Streptococcus agalactiae group B, previously called group B Streptococcus, Escherichia coli, and Mycobacterium tuberculosis, especially affecting the people with the compromised immunity, like the HIV patients. Other non-bacterial causes, viruses, enteroviruses, specifically non-polio enteroviruses, mumps virus, herpes virus, especially the herpes 1 and 2. Measles virus is also implicated in causing meningitis. Haemophilus influenza and other arenaviruses such as the West Nile virus, and even chikungunya and the dengue virus. Fungal infections especially affect people with compromised immunity, like Streptococcus is one of the commonest causes of meningitis in the HIV populations. Who are the people at risk of meningitis? As we said, affect all age groups, but particularly the very young and the elderly, because of the immunity is weakened for the elderly, and the immunity is underdeveloped in the young children. So this particular group of individuals, I need to take very carefully watch them whenever you have outbreak going on. People with weak immunity, like the HIV populations, the transplant populations, people with cancer, especially those that have metastatic malignancies, and people on immunosuppressive medications, like people who taking steroids, like people on chronic steroid use, like those with the chronic inflammatory diseases like rheumatoid arthritis, systemic lymphohistiocytosis, or people taking steroid for other reasons like asthma patients. This because chronic steroid use weaken immune system and can predispose an individual to contracting meningitis. Living in a group settings like overcrowded prisons, dormitories for student hostels, or even home care settings like the elderly home care or the orphanage homes. These are all places where you have individuals in a crowded group settings. This put them at risk of having meningitis, and then there will be potential epidemic when you have this. Then living in this kind of in this type of the geographical environment, the one we mentioned earlier, the meningitis belt. People who had head injury following trauma or spinal injury because of the leak of the CSF, the risk of communication to the outside, to the skin, is increased. These particularly are at risk of having staph aureus infections. Since we know it is a commensal on the skins, especially methicillin staphylococcus or resistant staph aureus has been implicated in this. Sickle cell anemia patients and alcohol use disorders. These are people at risk of aspiration, and then from there they can have pharyngitis, which from there it can lead to meningitis. Healthcare workers during epidemics are also particularly at risk because of the nature of their job and coming into close contact with people with infection. So how do we recognize meningitis? How do they present? Fever is particularly significant. It can start abruptly with fever, headache, and neck stiffness. These are the triad of meningitis: fever, headache, neck stiffness. Once you have somebody with any of this, you need to watch the individual and become alert. Nausea, vomiting, sensitivity to light, what we call photophobia. Individuals, if they develop meningitis, they become sensitive to light, and you will see them trying to cover their face from the light. And if the disease becomes so serious, it can lead to altered conscious level, confusion. There could be generalized body weakness, lack of energy. Other manifestations, like in the 2017 outbreak, we had an unusual presentation where a patient presenting with the diarrhea and vomiting. And this has been ascribed to particularly serogroup W and Y. During that outbreak, we had a couple of patients who present with these unusual presentations. This is just pictorial presentations of what we have mentioned earlier. The classical triad of meningitis are actually fever, headache, and neck stiffness. But in children, all these three, you might only get one, fever. So they will come with extreme lethargy. If they are infant failure to suck, they'll be able, and they become very irritable. So particularly the pediatrician and the pediatric nurses should take note of this. They may not present with the neck stiffness or headache, even if they are old enough to make complaint. But particularly they may have fever and lethargy, and then irritability and the other features. So the Nigerian Center for Disease Control put forward these definitions for ease. Any person with sudden onset of fever, especially during outbreak, will start this level of temperature, and they have any of the following: loss of consciousness, neck stiffness, rigidity, raised or features of raised intracranial pressure, or bulging fontanelle in children, in toddlers and children. Now, confirmed cases is any of those who has laboratory confirmation. There could be also a probable case, individual who has this disease and is epidemiologically linked, but he died before we took samples. So what do you do when you see how do you investigate these cases? Very important is the lumbar puncture for CSF analysis. Now, the importance of lumbar puncture can never be overemphasized, but that should not delay treatment and care because of the risk of mortality in these patients. Sometimes you could face with the logistic in getting the samples, and that should not delay you in commencing treatment. But it is very important to have the case confirmed using lumbar puncture CSF that can be taken to the lab for culture and for other analysis. This will help us confirm the serotypes we are dealing with, so that when we are deploying the vaccines, they could be more specific in deployment of the vaccines, and that could also give information regarding whether we are dealing with a new serotypes or there is an emergence of resistance of the already known serotypes. So if we didn't take these samples, we'll not be able to have this. Other basic investigations like the football count to be done to look at the WBC response. As we know, if it is bacterial, we expect to have neutrophils rising. If it is viruses, we expect the shift toward the lymphocytes. And then we look at the other parameters in the blood, which will help us in managing the patients. Electrolyte and creatinines, for those of that are co-clinicians, we know we can have syndrome of inappropriate ADH, which the EUCR can help us identify and have an idea. The analysis also be taken. One of the very common complications that the patient with meningitis can have is they can progress to have sepsis, and that can also progress to have kidney injury. So if you didn't do this investigation, we'll not be able to have that idea and then manage the patient appropriately. Blood culture is also important because sometimes if we couldn't get the lumbar puncture, we didn't get the organism there, the blood culture can help us, and especially the patient develop meningococcal septicemia, what we call meningococcemia. Malaria parasite is very important because often they mimic each other, especially in children that does not present with the classical triad of headache, fever, and neck stiffness. And then cerebral malaria is also very important differential diagnosis of meningitis. Also in the pregnant women, we know malaria and meningitis can cause serious illness in them. So we need to be. So this is just what we see in CSF. I think we should move out of it. So how do we manage this patient? Very important to start with the supportive care. We should ensure that these patients are properly nursed, and if they need oxygen therapy, it should be given. They need to secure their airway for those of them that convulse and lose consciousness. We need to make sure that they have the 3 tubes of life if they are unconscious, NG tube, airway, and the catheter and IV fluids cannula. Then prompt treatment, commencement of antibiotics. The drug of choice still remains ceftriaxone in the meningitic dose. However, during epidemics of Neisseria meningitis, still WHO still recommend use of penicillin if we have evidence to suggest substitutability. But ceftriaxone remains the drug of choice. It's wide coverage and is safe, can be administered both intramuscularly and intravenously. Older individuals, because of the risk of Listeria monocytogenes, they need to add ampiclos or ampicillin and or amoxicillin. Also in the children. In people with a compromised immunity, you might have to add rifampicin. Intravenous corticosteroids have been shown to improve mortality in the sporadic cases of meningitis. This has not been proven during outbreak, so we need to be careful in use of steroids during outbreak. Particularly, it is found useful in Streptococcus meningitis, which we know has been implicated in the sporadic cases. So during outbreak, use of steroids has not been shown to improve outcomes, and should be avoided. Then we need to take very cognizant of the complications of these patients and look at their hydration status, oxygen therapy, blood sugar monitoring, because these are all ischemia modifying factors that can affect the brain, and the patient can go into hypoglycemia if we didn't monitor the blood sugar very well. Hydration can go into severe dehydration, and that can lead to, can worsen the kidney functions, and then can also lead to other complications. So we need to also look at the nursing care of these patients to prevent bed sores, which are some of the complications, especially for those that are unconscious. So these are some of the complications that the patients can develop. Poor nursing care may lead to bed sores in those that are unconscious, and aspiration pneumonia if we didn't take care of the airway very well. Oxygen therapy. Seizure is one of the very important complications that the patient with meningitis can develop, so we need to address it and manage it aggressively. Hearing loss, these are some of the long-term complications, hemiplegia, and also some mental abnormality. These are the children that subsequently they become low IQ, and that can affect their behavior as they grow up because of the injury to the brain that the brain suffers earlier. Infection prevention and control, a very important aspect of these presentations. The mainstay of the prevention is during outbreak is actually vaccinations. So in the past we have used serogroup A and C meningitis vaccine, the one we call bivalent. We have also used previously monovalent vaccine Men-A, and as time goes on, in the next slide we will see that we have advanced to now we are using pentavalent vaccine. Post-observer prophylaxis with antibiotics is given to close contacts of individuals with Neisseria meningitidis. So whenever we have a household individual diagnosed with meningitis during this outbreak, we need to do contact tracings and give prophylaxis. We commonly use ciprofloxacin as a single dose of 500 milligram given to the household contacts that are very close to the patients. And some also use rifampicin 300 milligram in 2 doses. But early diagnosis and treatment of the index case will help to limit and prevent spread of the outbreak. Reduction in the household overcrowding and other poverty reducing measures will reduce overall susceptibility and transmissions. During outbreak, it's one of the things advocated. Visit prisons, decongest prisons, decongest hostels, look at the hygiene environment of those places. Slums, where we have slums, these are the areas to be targeted for vaccinations and also health stock. Then also hostel communities. Universal precautions should be taken, especially when caring with these patients. So this is very important for the healthcare workers. Hand washings, hygiene should be emphasized in between each patient. If the nurse comes to give medications, to do vital signs, in between each patient, you are encouraged to wash your hands so that you limit the spread of these infections. Use of personal protective equipment like face mask, hand gloves, gowns where necessary should also be encouraged. But we should know that meningitis is not COVID, that we have to pull in inter or full regalia. No. What we mean by this PPE is Your face mask is a personal protective equipment. Your hand gloves is also one of them. So we should understand all the use of this word appropriately. So what the new roadmap, now WHO with the support from partners have set a target to eliminate meningitis outbreak by 2030, and they have set out to support countries. We are lucky in this country, Nigeria in a historic move in 2024, we roll out for the first time in the world to start use of this vaccine, the pentavalent, that contain all the 5 serogroups that have been implicated in the outbreak. Last year we received about 1 million doses, and it was used with the essence of trying to curtail this kind of stations we are in currently. And rightly also, the Nigerian Center for Disease Control has deployed its supporting staff across the nations to support states that have reported outbreaks. So what is the prognosis of these infections? The case fatality, as we saw in the current outbreaks, is about 8.4. So we are still at the lower level. If we are lucky to curtail the outbreak early enough, we might not have to reach this level. But by early diagnosis, and that's why I'm happy that we are sensitizing ourselves. This center is the heart of the healthcare of these states, and therefore we are expected to receive patients with this kind of infections, and this presentation will serve as a kind of sensitization to all of us to watch and be vigilant, so that we also contribute towards the curtailing of this outbreak. So these are my reference. Thank you for listening.